Good morning, everyone, and welcome, and warm hello to those of you joining us live, and also to everyone who will be watching the recording later on. I'm really happy to have you here for the second session in our cTG series, and I'm especially grateful to welcome back Dr. Kirsten Small from Smalltalk. Thank you, Kirsten, for being with us again. And if you haven't seen part 1 yet, it's absolutely worth a watch. Dr. Small takes many of the common myths and cTG legends and breaks them down into clear, evidence-based reality. We'll share the link in the comments under the video. And with that, let's get started, and over to you, Kirsten.
Thank you very much. And we're doing a bit more myth busting today when looking at computerized cTG interpretation. So I want to start by telling you a little bit about where I'm coming from. So I'm currently based in Australia. It is early evening here, and it's just towards the end of summer, so quite different looking outside my front door at the moment than it is outside your front door, no doubt. I live on the Sunshine Coast of Queensland, more or less at the bottom of where that arrow is, and the traditional owners of that land are the Gubbi Gubbi people, Indigenous Australian people, and I would like to begin by paying respects to them for their ownership of the land, and it's just a really lovely, beautiful place to live. This is me. For those of you who are not yet familiar with my work, I have for many years had a blog post called Smalltalk, which I started fresh off the back of having finished a PhD about fetal monitoring. I've trained as an obstetrician and gynecologist and had a clinical practice that went for more than 20 years. I've now retired. I've worked as an academic. I do some research work from time to time. Mostly I am self-employed and provide education for people around fetal monitoring and occasionally some other things that attract my interest. So the plan for this evening's conversation is we're just going to start by talking about what actually is computerized cTG interpretation and a little bit of the backstory of it. There are two different times when it turns up in clinical use. One is using it during pregnancies before labour starts, so antenatal use of computerized cTG interpretation, and the other time is during labour itself, so intrapartum use of the cTG. I'm going to touch on the ethics of computerized cTG use and what we need to be aware of and what questions we need to be asking, and leave you with some future predictions of where I think this might be heading and what I see coming up in the research world around the use of cTG monitoring. And the plan is to give you some time to ask questions at the end. There is a chat box in the software, so if something comes up at some point while I'm talking that you'd like me to touch on when we get to the end, feel free at any time to just go to the chat box and type something in there, and we'll have a look at them all when we get to the final bit of the presentation. Now, the reason this came up is that Lenka shared this post that had appeared on social media and suggested the workshop. Now, I don't speak your language. I only have English. I'm a little limited. So I've had to have the help of some interpretation for this. And I can see that there are several claims being made about computerized cTG monitoring in this, that it is modern, accurate, more objective, it determines oxygen levels, it determines placental function, and it plans the timing of birth so that the baby can be born without injury from hypoxia. So keep those claims in mind as I take you through the evidence, and we'll see whether they're true or false, or whether there's no research really to answer the questions at all. Right, so let's begin with what actually computer interpretation is. Well, of course, originally cTGs were produced onto a piece of paper, and if somebody wanted to look at the output, then you had to walk into the space where the woman was, or somebody had to tear the piece of paper off and take it to the person who wanted to have a look at it. And it had the heart rate tracing at the top and the uterine contractions at the bottom, and people, if they wanted to write notes on it, would grab a pen and write on the tracing alongside it. We then shifted to digital CTGs in most places. There are still some situations where paper-based CTG monitoring is used. And so we've digitized the data and can then display it onto a computer screen rather than just onto a piece of paper. That has produced two big technology advances in the world of CTG monitoring. One is the ability to shift that data away from the woman who it originates from. So we've got central fetal monitoring systems where the data's in a central location in the same maternity service. So there'll be an office somewhere in the birth suite area or antenatal clinic or the ward or wherever, where every woman who's on a CTG will have her live CTG tracing displayed on a screen along with everybody else's. And there's also remote fetal monitoring options where the data is projected outside of the service. And that might be that an obstetrician's looking at it on their phone from their office or at home. In the US, they're now starting to have midwives and nurses employed in big facilities where they are paid to sit and do nothing other than to look at a bank of CTG monitors from a hospital somewhere else, so that the time that is taken to do CTG interpretation is now being outsourced out of the facility, so that they can make do with even less staff on the ground because no one locally is actually paying an awful lot of attention to the CTGs. Can see some problems with that particular application, but nonetheless, it's become fairly well established through the US. Now, there's always been some problems with individual clinicians, nurses, midwives, doctors interpreting CTGs. It requires a certain level of knowledge about how to interpret the trace. And it takes time to learn that skill. And then, of course, guidelines change and what's considered normal in one year becomes not quite normal in the next year and vice versa. And the language that's used to describe the changes in the heart rate pattern changes. So when I first started as a medical student, we were taught about type 1s and type 2s, and now we talk about earlies and variables and late decelerations, for example. There's a really big problem with variability of interpretation, and it's been well recognised. There's papers on this since about the 1980s, where if you take a set of CTG traces, you show them to a group of people, then you will get multiple different interpretations as to whether that CTG is normal or not, and even what to call the individual bits of the CTG tracing. And not only is there inter-observer variability, so Dr. A says something different to Dr. B and midwife C says something different again. If you then show the same CTGs to that group of people a couple of weeks later, Dr. A might have said it was normal last time, but it doesn't necessarily mean he's going to say it's normal this time around. So there's intra-observer variability. Our ability to reliably call it the same thing every single time is akin to reading tea leaves for predicting the future. It's not all of that great. And so the second problem that digitized CTG data has been used to solve is this problem around people who may not have the knowledge to interpret the CTG, or who call it something different each time they see it, interpretation variability, and the fact that people aren't necessarily able to sit and look at the CTG tracing all of the time. They're busy putting in an IV or going and getting medications, and so things can happen when their back's turned. And so the decision then was, okay, well, why don't we aim a computer at this data and get it to pay attention to what's going on? And the first computer interpretation systems were designed around, okay, we have this particular guideline and it says that, you need to look at the baseline. So we'll teach computers to work out what a baseline is and to count the heart rate, and then flag if it's above or below a certain number, and we'll teach computers to look for accelerations and decelerations and the timing of decelerations and how long they are. And then usually it produces a color coding so that when the CTG is considered normal by the computer, it'll be green, and it'll have, you know, orange, yellow, red as it becomes increasingly outside of the range of normal based on that interpretation. As you'll see, there's been a reasonably good amount of research around those clinical designed algorithms, and one of the problems is that if our understanding of fetal physiology is inaccurate and the patterns are not telling us the things that we have been taught that they are, then no amount of teaching computers to think the same way that humans do is going to fix the problem if the humans have it wrong in the first place. So the second round of what's been happening in the world of development of computer interpretation of the CTG is basically to give the computer a whole pile of CTG traces where the clinical outcome is known, and let them have at it and figure out for themselves what are the patterns that distinguish the babies who have healthy outcomes from the babies who don't. So that's artificial intelligence or machine learning. There's a whole pile of different terminologies reflecting the slightly different approaches that are being used to achieve that. The use of computer interpretation in pregnancy and during labour, the approaches are slightly different, and the aims of what you're trying to achieve from that are slightly different. In essence, what you're hoping for is a computer reading that says, this is normal, you can keep going. That's a reassuring sign, and things get a little bit messier when it's not normal, and trying to decide what to do on the basis of that is a little trickier. So let's start with antenatal interpretation. And my understanding of that Facebook post is that that's the equipment that was being discussed with that is the Dawes-Redman system. Now, Dawes-Redman started it became used clinically in was it Oxford, Sheffield, I think, in the UK in 1991, and as I said, this was a group of people who sat down and said, this is what we think a normal CTG is. And so they trained the computer to look for those things and to then tell you when the heart rate pattern met criteria, when the baseline was normal, when there was normal heart rate variability, when there had been acceleration, so you know the production of a reactive CTG, and the machine would alert you, and you could then be reassured that this was a baby who had a normal heart rate pattern, and you could take the woman off the CTG monitoring. And those criteria were based on the FIGO guideline at the time, International Federation of Gynecology and Obstetrics guideline. So the first question we need to ask is, do the heart rate patterns predict outcomes well? Do the heart rate patterns that they were teaching these computers tell the difference between babies that are healthy and that are not healthy? And they did 2 bits of research using their system that were designed to help to understand that. And they did find that there was a correlation between what they had decided was an abnormal heart rate pattern and with cord blood acidosis, so having a low cord pH at the time of birth. But the research was only done in small for gestational age babies, not in babies that were considered to be a normal size or that were even bigger. So there are some problems with this. If you're not expecting a baby that's small, there's absolutely no evidence to suggest that those particular heart rate patterns are linked to a particular outcome, because that research hasn't been done. People just have assumed that if it's true for small babies, then it's true for all of the others, and that may or may not be the case. The other issue here is measuring cord blood gases as the thing that you're interested in. Cord blood gases are actually only weakly predictive of a poor outcome. Babies who are born in poor condition, who end up having brain injury or who die soon after birth, are more likely to have a low cord pH, be acidotic. But most babies that are acidotic actually do fine. It's not a particularly useful predictor. What we don't know is whether these heart rate patterns will predict the more meaningful outcomes that parents are interested in. Is my baby going to be okay or not? Is it going to die? Is it going to have a brain injury? Is it going to have cerebral palsy? Is it going to have problems with learning speech when it grows up, or being able to coordinate its muscles? We don't know because no one's ever actually done that research. So, you know, we see that there's beginning to be a bit of a problem here in terms of the development of the base level research that should have been done first before these systems were introduced. But nonetheless, they have been introduced into clinical practice, and there have been 2 randomised control trials that are summarised in a Cochrane review. So the Cochrane review is Gravel 2015. The 2 trials are quite some time ago. So the first was done in Africa, and all of the women in this research were preterm, and all of them had preeclampsia. The other one was done in New York in 1999. All of the women were considered to be high risk with a whole range of different conditions that got them into that high risk category. And as well as using cTGs, they were also doing ultrasound scanning for biophysical profile scores. So you can't actually pick out from the research whether it was the computer interpretation that was making a difference or the biophysical profile scores. In the overall mortality rates, there were less babies who died in the group that were randomized to computer interpretation of the cTG. However, once they took out all the babies that had congenital abnormalities, the statistical significance of that disappeared. So there is actually no significant difference in the incidence of preventable deaths, whether you're having a doctor and a midwife look at the cTG themselves or whether they're first having it interpreted by the Dawes-Redman computer interpretation system. There was also no differences in any of the other outcomes like acidosis, admission to the nursery, and so on and so forth. When I've gone and actually got these 2 original papers and have had a good look through them, and the deaths that appear in that African study read very much to me as complications of prematurity. So they've got things like pulmonary hemorrhage, sepsis, necrotizing enterocolitis, rather than being things that are related to low oxygen levels during labour. The deaths in the New York study included, for example, a stillbirth at 38 weeks that happened 4 days after a cTG was done with clinician interpretation for a woman with diabetes. And all of the other deaths in that study were babies who had congenital abnormalities. So, you know, while we have 2 randomized controlled trials, the quality of this research as the basis of widespread clinical practice doesn't have a lot of solid grounding underneath it to stand on. There's been one more recent piece of research. So those ones were done in the 1990s. That was a little while ago. This most recent piece of research comes from Davis Jones. It was done in the UK. The data was collected between 1991 and 2024, and this was a retrospective analysis of cTGs that had been collected during that time period from 3,316 women who had given birth, and it was published last year in 2025. They didn't look to see whether using computerized interpretation using the Dawes-Redman system versus standard cTG monitoring or versus intermittent auscultation or versus not listening to the heart rate or ultrasound scan or any other comparator improved outcomes. What they did was looked at cord blood gas results on the babies, and then looked at back at those CTG patterns and whether the system had said it was normal or not normal, and calculated the positive and negative predictive values from that to see how good is the system at predicting what the outcome will be. So negative predictive value means that this is a normal looking pattern. The computer says it's normal. What's the chance that this baby is actually born healthy? It's fine, because that's what we really want. We want women to be able to go in saying, I'm a bit worried about my baby. Here, let's do this test. It's normal. The chances of you having a problem are really small. You can go home and you can relax. It's going to be okay. And how well it performs depends, not surprisingly, on how likely it is that that person's going to have a poor outcome. So 99% in a very low risk population will have a good outcome, and 72% in the high risk population would have a good outcome. Now, this first number is not all that surprising, because the kind of outcomes that we're looking at in a low risk population affect about 0.2% of people. So if all you had done was say hello to them, that would be about the chance that they would have a poor outcome in the first place. So it's not that the computer's really changing that for people. And 72% in a high risk population basically means that so a woman who's got risk factors, you know, she's got a small baby, she's got preeclampsia and the baby's not moving very much, she has a normal Dawes-Redman computer assessment, there's a 1 in 4 chance that her baby's going to have a poor outcome. Which I think, if we were honest with people, I think they would think, well, that's not a very good result. I think a 1 in 4 chance of still having a poor outcome is not actually all that reassuring. Thank you very much. The other thing that they looked at is the opposite of this, positive predictive value. So when the computer said that the heart rate pattern was not normal, how good was it at telling the babies who were not healthy after birth? And in the low risk population, not very good. So when the test was abnormal, only 1.9%, so basically 2%, 1 in 50 women had a baby that had a problem. The vast majority of the babies were still okay, and that rose to a 50% chance in the high risk population. So some form of careful risk assessment is needed in order to improve the ability of the system to be able to predict the outcome. And I wonder whether just some careful form of formal risk assessment might actually do a better job of picking the outcome than putting a computer on and asking it to tell you whether the heart rate pattern was normal or not. So when we come back to this and look at the claims that they made and to see how they match up with the research that we've just done. So firstly, they said that this system's modern. Well, it's 35 years old. So, you know, the term modern can mean different things to different people, but the computer interpretation technology itself actually isn't all that new. It's basically been around for as long as we've had personal mobile phones. So it's, it's an interesting claim. Is it accurate? Well, we have to ask accurate for what? Do we have any evidence to know whether it's accurate for predicting which babies are likely to die or have brain injury? Not really. You know, we've got a little bit of evidence from that 2025 study that if you're at particularly high risk, it does reasonably okay at predicting the babies that are going to be unwell, and not so accurate at predicting the babies that are going to be healthy if you have risk factors. Is it more objective? Well, that's true. It gives a clear, this meets criteria or it doesn't meet criteria. But that objectivity doesn't necessarily translate into clinically useful information. And there are times as an expert clinician when I'll look at heart rate tracing and knowing a woman's particular story, when the answer is it's sort of okay, but it's not really, and knowing that subtlety to know that there's sometimes a grey zone in the middle can actually be really clinically useful, and having a clear yes and no answer isn't necessarily going to help. Because there's another way to get a really clear yes and no answer, and that's to grab a coin and flip it in the air and see which way it lands. You'll get a yes answer or a no answer. So that objectivity doesn't necessarily mean that you're actually predicting something in a useful way. Does this determine oxygen levels? No, it determines heart rate. It doesn't measure oxygen levels at all. That's a false claim. And it's been assessed against acidosis, not against oxygenation during labour. So or during pregnancy, we simply don't know how it correlates with oxygen levels. Is it able to tell what's going on with placental functioning? No, it just has nothing to do with what's going on with placental functioning. Can it plan the timing of birth so the baby is born without injury from hypoxia? Well, no. People plan birth timing, not the Dawes-Redman system. It isn't designed to provide any guidance at all about the timing of birth. It simply says this is a normal antenatal cTG or it's not. And it's up to the clinician to then make a decision as to what to do with that information. And as you've seen from the research, there's nothing to suggest that using this system rather than using another way of assessing well-being of the baby during pregnancy can prevent birth injuries from low oxygen levels. So if you want to go ahead and introduce computer interpretation because you think it's fun and it's kind of neat and the machines look great and it's new and woohoo, aren't we up to date, then by all means go ahead. But please don't go around making any promises that it can predict things that it can't predict, that it's accurate at something or other, who knows what, or that it's going to make things better when there's actually no evidence of that. The only really useful thing that these computer systems are doing are to generate profits for a technology company. They're not making life better for women or for their babies. And, maybe they're making life a little bit better for clinicians because they can put the machine on and walk out of the room and come back when the machine goes ping and says that this heart rate is fine. That's the antenatal stuff. And I want to move on to computerized cTG interpretation during labour, even if it's not currently an issue for you, because it's coming. And I want to give you some prior warning about the fact that it's coming so that you are prepared for it and can ask the right kind of questions. And again, we start with these clinician-trained systems. We haven't yet in the antenatal period moved into having artificial intelligence systems in the research, but that it will come. I'm aware of 5 commercially available systems. If you're aware of any others in Europe that I don't know about, then let me know so that I can go and learn about those ones as well. Infant was developed in the UK and it uses something that's fairly close to the NICE guidelines from the UK as its interpretive framework. The Omnivusis Porto system is Spanish and it uses the FIGO guideline. Pericam is Canadian and it uses the NICHD guideline from the US. Trium is German and it uses FIGO, and Oxysys is from Oxford in the UK, and they use a different approach. They use a thing called total deceleration area to tell whether the cTG patterns are normal or not. But these are things that humans have decided are worth looking at, that they've taught the machines to actually go looking for. And these have been more thoroughly evaluated than have the Dawes-Redman system. This summary comes from a systematic review published in 2023, which is the most recent one by Cipera. So they found there's 5 randomized controlled trials. One of them's small and only had 720 births and showed a reduction in acidemia and the caesarean section rate, but none of the other 4 trials, including the infant trial, which was the largest of them all at 46,000 births, showed any improvements in perinatal outcomes, in maternal outcomes, and it was not cost saving overall. That small positive trial was done in Bulgaria and they used the FIGO interpretive guidelines. So, given that there's no really stunningly standout evidence that If human beings tell the computers what to look for, it doesn't seem that we're actually doing a great job of improving clinical outcomes. What if we got out of the way and said to the computer, here's 1,000, 10,000 CTGs. These ones come from babies who were born in really healthy, normal conditions, normal cord gases. They didn't go to the nursery. They had normal Apgar scores, didn't need any resuscitation, didn't have seizures. And these ones that come from babies that had these kind of problems, you go and figure out what's wrong. And there's a whole pile of different approaches that are used by technology developers to come up with a way to interpret the CTGs that go by the names of things like convoluted neural networks and artificial neural networks, fuzzy logic, machine learning. They've also let large language models at it, and that's things like ChatGPT to interpret CTGs. And I wrote a blog post about that late last year if you're interested in whether ChatGPT can interpret your CTG for you. No, it can't. Don't do this at home. When in the research that's been done so far about these systems, they're mostly looking at the ability of their system to either predict or rule out the presence of acidosis, which, as I said, isn't a really great predictor of meaningful outcomes for babies. Anyway, it's just something that's easy to measure, and you can do it immediately at birth, unlike looking for things like cerebral palsy or even perinatal mortality. You have to wait till the baby's a week old if you're measuring early neonatal mortality before you can say whether it's happened or not. The best summary paper that I've been able to find is one by Barnova, and even they say it's really difficult to be able to compare this researcher's system with this researcher's system because they're not measuring the same things in the same population. So we're not yet at a point where some kind of meta-analysis comparisons can be made to know whether any of them compare better with any of the others. There's quite a lot of this research going on though, and most of the papers that I see that have compared it with having expert clinicians look at the CTGs, experts are still doing slightly better than the computer systems. What I do see in the literature is this sense that there's a very large pot of gold waiting at the end of the rainbow for the research group that can finally crack this and get a system that works better than human beings, and even that works just as well as human beings, because then we could replace the need to have somebody actually look at the CTG. You would just simply wait until the machine made a loud noise in the corner of the room, and all of that work around CTG interpretation would be delegated to a computer instead of a human being. Do we as yet have any research that looks to see whether using artificial intelligence for CTG interpretation improves clinical outcome? No, we do not. And we do need to be careful about how that research is done. And really what we need is for researchers to make sure that they're measuring outcome measures that matter to families. So babies that die, babies that have cerebral palsy or neurodevelopmental delay, babies that have hypoxic ischemic encephalopathy who have seizures and end up in the nursery. Measuring something like APGARs is not really all that useful. If your baby has an APGAR of 6 but is completely fine at 10 minutes of age, so what? Like, really, it's not a big deal. And likewise, if your baby had an APGAR of 9 at 5 minutes but now has cerebral palsy 18 months later, it's not a useful measure. We need things that are clinically relevant, which puts the cost of the research up significantly and the time duration that it takes to do it up significantly. And so whether or not the tech development companies will actually do what is required to do a proper analysis or not remains to be seen. Which brings me to some future predictions. So where actually are we headed with all of this? I see in the literature some directions that look likely to continue for a while. I think that, I mean, it's an area of active research and development, and there's a lot going on in that space. I'm personally supervising a PhD student who's looking to develop a computer interpretation system. That kind of happened by accident. I don't know how I got here, but I'm along for the ride, and to make sure that she actually gets the ethics part of all of this right. I think where it will go next is into what's called decision support systems. So it's not just going to tell you whether this heart rate tracing is normal or not. It's going to tell you, you should do a cesarean section. You should get this baby out now, because it's going to take the heart rate information and it's going to combine it with information from the woman's history. You know, she's had a stillbirth before and she's now in labour at 28 weeks is a very different story to a woman who's in labour at 39 weeks with her third baby and all of her other two kids are completely healthy. And with other things like blood pressure and meconium staining of the like, and the estimated fetal weight and so on and so forth, to build a better predictor than can be achieved just from heart rate patterns alone. The other area that I see where research is being done is the development of wearable technology for long-term antenatal monitoring. So a woman who's got a growth-restricted baby, for example, instead of coming into the hospital a couple of times a week to have a cTG monitoring, she'll be given a device that she can apply at home that she can wear for days to possibly weeks at a time, and that data is then sent back to the hospital via a computer interpretation system that then flags somebody at the other end to say, hey, it's suddenly not normal. To do that, of course, you need to come up with different ways to monitor the fetal heart rate, because you can't use Doppler because that's not considered safe for long-term exposure, because pushing ultrasound waves continuously at a fetus for days or weeks at a time can cause heating effects and cause damage to the tissue. So non-invasive fetal ECG. Phonocardiography sounds very flash, but it's actually just using a microphone to listen for the actual sound that the fetal heart makes, like listening with a stethoscope, a pinode stethoscope or a regular stethoscope. And another one called magnetography, which uses very subtle changes in the magnetic fields that are associated with the movement of the fetal heart. The other thing that I think will come online in future development is to do more than just heart rate monitoring alone. In Australia, there's some research being done on adding continuous lactate monitoring so that they'll measure lactic acid levels using a device that looks a bit like a fetal scalp electrode, so a thing that screws through the surface of the skin of the baby's scalp. There's quite a lot of development going on to develop near-infrared systems that can measure oxygen levels in the baby and in the placenta with a device that is worn externally on the woman's abdomen rather than something that has to be inserted through the vagina next to the baby. The other thing that I've seen, but a while ago, but I haven't seen any more recently, was EEG monitoring, so measuring brainwave. That was like the lactate monitoring is invasive and would require, again, something like a scalp electrode attached to the baby. But it means that then you would have multiple channels of information coming in, and that might potentially be useful. Because it's a bit like if you went to the emergency department and said, I'm feeling sick and I'm not really sure why, I just don't feel quite right. If the only thing they did was take your pulse, you would think they weren't very good at their jobs. But if they took your pulse and your blood pressure and your heart, and they measured your oxygen saturations and they measured your respiratory rate and they did some blood tests, then you'd be thinking, okay, they're starting to get a good picture of what's going on. And I think that's where we're going to go with technology development, that we're going to move beyond just monitoring the heart rate to monitoring other things as well. In terms of what's going to happen in the clinical space, look, I am really concerned that what's going to happen is a bit like what we've seen with CTG monitoring in the first place, a bit like what happened with the Dawes-Redman system when it was introduced in the 1990s. The same thing that we've seen with central fetal monitoring, and that is that people go, oh, it's new and it's shiny and it's sparkly, I must have one. And so it gets introduced into clinical practice before the research ever gets done to prove whether it works or not. And then after it's in clinical practice for a few years, people go, well, it would be unethical to randomize people to research. You couldn't possibly do that. And so we'll may end up with the problem that we've arrived at now with so many other things that we have as part of the package deal of fetal monitoring, where it probably doesn't work. We don't really know for sure, and it's really hard to get rid of it because you can't also prove that it doesn't actually work or that it is being harmful, because to do the kind of research that would be needed to answer that question is now considered inappropriate. I think that these systems will drive increased intervention and I saw a bit of this happening during my PhD as they were getting ready to introduce the infant system at the hospital where I was doing data collection. Having gaps in the CTG tracing is something that the computers don't cope well with, and so there was more pressure on women to have fetal spiral electrodes put on, and that meant that they had to have their membranes ruptured, and that meant that they were in more pain, and so they had more epidurals. When that was fine for the clinicians because they could just kind of wire the woman up to the epidural pump on one side and the CTG on the other side, and that made their life a little bit easier than having to actively work with a woman who was in pain and trying to find a fetal heart while she was actively moving around the room. All in all, these systems really work to reinforce that idea that doctors are the saviours and that obstetric knowledge is going to save the day, that they're the clever people who know what they're doing and they're the ones with the technology tools. And that, you couldn't possibly give birth outside of a hospital setting because they don't have the fancy, expensive machines, and that would be a dangerous thing to do, despite the fact that there's ultimately no proof that these systems are actually producing the kind of results that people are claiming for them. And because that brings us to the question of the ethics of these systems. And their computer interpretation systems are what is known in the technology world as a black box, basically, that you've got raw data coming in one side and this is okay or not okay message coming out the other side, but you can't really see what's going on in the middle. And particularly with the artificial intelligence systems, where we're just letting computers figure out what to make of the CTG, they're finding things that we cannot see with the naked eye. So you can't sit and look at the CTG at the same time and go, oh, I bet this computer's going to say that's abnormal in a moment, because it's looking for things that you and I can't actually pick on a CTG pattern. And so what does that mean when it comes to informed decision making? So I don't know if you're aware of it. There's a skit from a British comedy show that was called Little Britain, that has somebody standing behind a computer furiously typing away at the keyboard and would look up and say, the computer says no. And I feel like we're going to be in a situation where women are, turning up with concerns during their pregnancy or during their labour, and the obstetrician walks into the room and says, you're having a cesarean section. And the woman says, well, why? And he says, I don't know, because the computer said so. Well, what would happen if I said no and we didn't have that intervention right now? I don't know. It makes it impossible to make good quality decisions if you don't know what's going on inside the decision making that the computer is doing. You have to trust that the machine's actually getting it right somehow. And then if there's a poor outcome still, who's going to get in trouble for that? Is it if the baby's born in poor condition, or the mother has a serious complication from having an intervention, is the doctor responsible for the bad outcome if they are doing what the computer told them to do? Is it the hospital executive who decided to approve the purchase of the computer system? Is it the tech developer who designed the system and maybe they introduced a fault into it so that it's doing this consistently and causing problems everywhere? You can't sue the computer. So those lines of accountability are really unclear in a way that is very clear when you've got clinicians looking at it. You know which doctor and which midwife had their hands on that CTG and who made the decision about what to call it and what to do as a consequence of that. We also need to ask ourselves, what happens if this artificial intelligence approach works and works so much better than we're actually able to achieve in clinical practice? What do we then lose? What skills in keeping women safe get lost? What then happens when the internet goes down or the power goes off? And what happens in the low and middle income countries when they're priced out of being able to buy these kind of systems and they're left behind? Or even in a wealthier country, there are pockets of areas where people can't get to well-serviced healthcare systems and have to make do with other options. Will it be used to increasingly coerce women to give birth in hospital facilities and to make use of cTG monitoring? The other question that comes up is that at the moment, a reasonable proportion of the authority of obstetrics is derived from being seen as experts in interpreting fetal heart rate patterns and deciding when and what intervention is needed. And you only just need to go and spend a bit of time hanging out in birth suite to know that when the heart rate pattern's abnormal, what happens? You call the doctor. Midwives are not considered the decision maker in this situation. They don't get to call the operating theatre and say, hey, I'm bringing a woman around for a cesarean section. Can you organise somebody to do the surgery for me? The doctor is the person who makes that decision. What happens if that decision making is now being reliably replaced by a computer that's actually working better than the human beings? Obstetricians potentially then just become cesarean technicians and they lose their authority as a professional. And the tech developers would end up being the more powerful professional group. And that might have significant effects on who gets funding, how much doctors get to charge, whether people want to train in the profession or not. So we need to be having some serious conversations about this stuff before it just launches into widespread use. Now, I want to leave you with some practical things that you can do, because all of this can feel a little bit scary and a little bit theoretical, but there are definitely some things that you can be doing right now. And the first is to ask good questions. You know, why are we buying this machine? Why are you suggesting I have this machine used? Why can I not have another alternative? What are the other alternatives? What does the research say? For those of you who are in clinical practice, we owe it to our colleagues and to the people that we're providing care for to tell the truth about the fetal monitoring evidence and not to run around saying that this fancy new machine can predict oxygen levels and tell the best time for the baby to be born and it'll prevent brain injury, because none of that's actually true. And we need to stop saying things like that. And we need to challenge people when we hear them saying things like that and say, really, show me the evidence, because that's not what the Cochrane Review says about it. We should be demanding proper evaluation of technology before it is introduced into clinical practice. And if a hospital wants to buy it, then the clinician should be asking for proof that it actually is going to improve something and not just be a huge drain on resources. And of course, that requires us to have done the proper research in the first place. And if any of you are keen future researchers, then like Muba, my PhD student, you might be interested in actually going and doing some good quality research and trying to answer some of these questions for us. Now, that's all I have planned for you, apart to say that due to some good luck, Lenka happened to invite me along on the same day that I opened enrolments for the Fetal Monitoring Academy. I promised I didn't change the date to fit this. It had been decided before we had this conversation. So I'm actually running a half price early bird offer. So if hanging around with me more and learning more about fetal monitoring is something you are interested in, then I suggest you take fairly prompt action to get the discount on it. And if you scan that, I can send you more details. Now, what you'll get at the far end of this is a feedback form asking for your name, your email address, and a bit of feedback on today's presentation. Once you've submitted that, you are going to get a copy of these slides and the reference list that sits behind all of this. So all of those citations that I've talked about. So you can go and check, and believe in being very open about where I get my information from. You can go and check all of that if you want to have a look at it for yourself, or if you want to be able to wander into a hospital and go, this person said that this is not actually accurate. So feel free to grab that, and I will leave it up for a moment. But the next slide simply says, we're done and now it's time for questions. So I'll leave that up for a moment, but yeah, shortly I'll stop screen sharing so I can move all of the 25 things out of the way for you. And I'll have a sip of water.
Thank you very much for the presentation. Oh, you left us with so many questions. It seems as we are moving towards a level of surveillance in pregnancy and labor where physiology has less and less space to unfold. Almost like really being nearer to the tipping point, don't you think?
Yeah, and unfortunately, a lot of this surveillance is not based on a good understanding of physiology either.
Yeah, and the real questions I had for us to wrap it up, is there actually any kind of situation when you would definitely recommend the use of cTG?
When a woman asks for it, you know, I think that all women should have a conversation about the different ways to monitor the baby during pregnancy and during labour with their care provider during their pregnancy, and should have the evidence laid out for them so that they can make their own decision about it. And if they go, okay, no, I still quite like the idea of having a cTG, even if it doesn't work a lot, I think I'll just feel safer. Fabulous, great, go ahead and do it. What we consistently get wrong, though, is the whole, because of risk factor X, Y, and Z, you have to have a cTG, and there's actually not a conversation at all that's really sufficient in terms of getting women's informed consent. In terms of clinical situations, the closest that I can come to it is the use of oxytocin for induction of labour or for augmentation. Having said that, there's never been a randomised control trial that compared only a group of women who were on an oxytocin infusion who were having cTG monitoring with a group who had intermittent auscultation to know whether there was a difference or not. And, you know, ultimately you would need at least one, if not multiple, randomised control trials to answer that question. The reason I say that is that there's a subgroup analysis in the Dublin trial, so the McDonald 1985 paper, which was the largest of the randomised control trials, and they looked at women who had an oxytocin infusion. And in their study, it was predominantly for labour augmentation because they didn't really believe in induction of labour. They had an induction of labour rate of 3% in a tertiary hospital, which is just unspeakable in this day and age to have one that's that low. But they had a high augmentation rate because they insisted that all women give birth within 12 hours of arriving at the facility, and if labour was a bit slow, then everyone ended up on oxytocin. And they found that if intermittent auscultation was used rather than CTG monitoring, then the neonatal seizure rate was higher. So it does seem to be that there might be some benefit from CTG use in the face of oxytocin use. Having said that, the way that we provide care for women who are using oxytocin in labour is vastly different now than it was in the early 1980s. It was all being manually titrated through, rolling the little stopcock up and down and counting the drips in the chamber. There was no automated infusion pumps like we use today that deliver exactly 5 mils per minute or whatever it is that you program the machine to deliver. And the people who were in the room who were feeling contractions and who were titrating the infusion pump were mostly midwifery students in the Dublin trial. And we, again, I hope no one in your country, certainly no one in my country, would leave a midwifery student alone with that level of responsibility to manage an oxytocin infusion independently. And that shows up when you look at the incidence of neonatal seizures in the group of people who had CTG monitoring who were on an oxytocin infusion in the Dublin trial was 36 in 10,000 births. If we look at the, I'm going to get the name of it wrong, was a USA-based trial recently that done that looked at elective induction of labour at 39 weeks of pregnancy in primiparous women compared to later birth, mostly later induction of labour. And in their early induction group, who I presume will all have had CTG monitoring, the incidence of neonatal seizures in that group was 9 per 10,000, not 36 per 10,000. So 2 groups with CTG monitoring with oxytocin running, and the only thing that's different is the care that gets wrapped around the women. So I suspect it doesn't apply anymore, but it is, I get asked this question a lot, it is the closest I can get to saying there's one situation under which there's some evidence to suggest that CTGs actually will do some good for people.
Thank you. Maybe we got time for one question from the audience. Is there someone who would like to pose the questions from you girls here? Right. Go ahead, Maria. Your microphone. Maruško.
Thank you, Kirsten, very much. I would like ask you, how is it with CTG in second stage? Maybe I ask Lenka, help me with my English. Já bych se chtěla zeptat hlavně na tu praxi, která tady je, že se to cTG sundá a pak se ta sonda používá jako intermitentně po kontrakcích. Můžeš to nějak, rozumíš tomu?
Yeah, I understand, and I will try to translate it. The question is around the intermittent use of CTG. They take it off the belly, and they only use it after contraction to intermittently CTG the woman. So what's your take on that?
Do you mean at any point in labour or specifically during the second stage of labour?
Specifically during the second stage of labour.
There's one randomised control trial that compared intermittent use of CTG monitoring with continuous CTG monitoring, but it doesn't sound like what you're describing. What they were doing was 20 to 30 minutes of CTG monitoring every 2 hours and then intermittent auscultation with a Pinard or a Doppler in between time, and found no difference in outcomes. There's a myth that I have on my list of things to write a blog post about, but it hasn't hit the top yet. There's a myth that in the second stage of labour, the fetus produces different fetal heart rate patterns and that they have a different meaning when you see them to when you see them in the first stage of labour. And that's not how physiology works. If the oxygen levels go low, the response of the fetus and of the newborn baby, because they're the same thing, is exactly the same. And they have no idea how big the hole in their mother's cervix is, or whether they're high in the vagina or low in the vagina. So the idea that, it's just a second stage, Tracy, you expect to see some decelerations because the head's being squeezed, all of that turns out to be myth and not particularly true. So I think for starters, particularly for midwives who tend to be the ones who mostly believe it's just a bit of head compression, I don't need to get the doctor. And then they have a baby that comes out unexpectedly and flat because they weren't expecting it. It's because there actually really was quite a lot of decelerations, and that baby was having to work very hard because its oxygen levels were low for quite some time. So it's not necessarily harmless. I think and teach when I teach people how to do intermittent auscultation, I tell them it is really important that you listen during contractions, because it seems to be that and this is the reason the Oxford system, their computer interpretation system went with this thing called total deceleration area. That idea seems to be the best predictor of outcomes compared to FIGO guidelines, ACOG, any of the other interpretation frameworks for looking at a cTG. And basically it's the concept that if the heart rate is spending a long time below the baseline, that's a bad thing. And it can either be because you're having really deep decelerations but they're quite short, or you can have tiny little shallow decelerations that go on for a very long time, or maybe you're having quite small decelerations but they've been happening for 2 or 3 hours and they add up over time. Because if you reduce oxygen levels, the one thing that consistently happens with the fetus, which is a protective mechanism, is to slow down its heart rate. You do not need as much oxygen to keep your heart healthy if your heart rate's 60 than if it's 120. So what you're seeing with the deceleration is not distress, it's an attempt to cope. And we don't have a mechanism to be able to tell the difference between I'm coping and I'm in trouble now. They look exactly the same. All we can do is go, that baby's been doing an awful lot of coping for a very long time. We really should do something about it. So when it comes to second stage, if it happens for the first time ever in second stage in a woman who's pushed 3 babies out of her vagina before and usually does it in under 15 minutes, then it's probably not a problem, because by the time this baby starts building up any problems from its low oxygen level, it's going to be in her arms. If it's a woman who's had an abnormal heart rate pattern on and off over 6 hours and is now in second stage and has been pushing for more than 90 minutes, you do not want to be dismissing that heart rate pattern, and you do not want to be not listening during contractions, because that's when the decelerations are, and you will miss the fact that this is a baby I've been doing an awful lot of coping and I'm probably not okay anymore, because by the time that the contraction's finished, let me go and find the cTG and turn it on and let me get the gel and where's it gone? It's had plenty of time to recover, and so you'll miss most of the decelerations and be unaware of the fact that that's going on for babies. Hope it was very long-winded. Hopefully that gave you some useful information to think about.
Thank you for that, Kirsten. And thank you so much for today, for the clarity, the depth, and the courage to ask and answer some uncomfortable questions. And thank you to everyone who joined us live, and to those who will be watching the recording later. We will share the link to the recording and the registration form in the comments under the video. Have a lovely day, and may we keep moving toward the care, truly modern, human, safe, and evidence-informed and evidence-based. Thank you very much.
Thanks for your time, folks.